to turn it over to Dr. Jacobson-Dickman.
Thank you so much. And Dr. Rishti, you're certainly welcome to join, but we also do understand if you have a busy day. So wonderful for you to be here.
Thank you.
A little self-conscious coming after these tour de force discussions, but Dr. Carla Boutin-Foster and I do have the honor of the next session, and I think we're going to go straight into it. So if you will bear with me for a moment, I'm going to share our slides. It is really my honor to just be participating in the symposium, but specifically at this moment, it's my pleasure and honor to be partnered with a colleague who I admire tremendously, Dr. Carla Boutin-Foster, who's our Associate Dean from the Office of Diversity in Education and Research, and Professor of Medicine, no less. And really just an inspiring voice. So what we are going to present today is a bit of a shorter talk, will probably be about 40 minutes or so, that we've titled Reimagining the Chief Complaint from Presentation to Consequence. If you can just bear with me for one moment yes. Okay. So what are our objectives today? We plan to review the goals of the medical interview and the role of the chief complaint. So back to the basics. We hope to help you recognize how role modeling shapes learners' language choices, biases, and behaviors. We hope to examine how demographic details and stigmatized chronic illness labels or language can perpetuate stigma and diagnostic inequities. And finally, to apply the REACT framework, which we'll go much more into, to critically examine and revise chief complaint documentation. So according to Coulihan and Block, in the medical interview, the main goals of the medical interview are to establish a therapeutic relationship. This is building trust and rapport through expressions of empathy and other. To gather information, which is to obtain accurate, comprehensive data about a patient's experience. To provide information, which refers, of course, to educating and counseling. To develop a treatment plan, which is really a collaborative process of making choices about diagnostic or therapeutic approaches that align with a patient's needs and values. And finally, to support patient health behavior and self-management by encouraging healthy choices and by motivating our patients and by empowering our patients. These goals reflect both the biomedical and humanistic aspects of care, balancing data collection, synthesis, and analysis with relation-centered communication. A wise clinical skill mentor of mine used to refer to this balance as tapping your head while rubbing your stomach. These are very complex skills, particularly as they're being accrued by our more formative, in our more formative years by our students now. And so what are the main goals more specifically about the chief complaint? Well, to accurately identify the primary reasons for the patient visit, to clarify the main symptoms or concerns, to establish focus and direction for the interview and for defining the central problem. And so in these ways, the chief complaint establishes the focus and the direction of the medical interview, the ensuing physical examination, the diagnostic evaluation, making it really the first and arguably the most pivotal step in shaping critical reasoning, diagnoses, and ultimately patient outcomes. So, in other words, it's a big deal. And so depending on the prominence within the patient narrative, Specific details typically gathered when eliciting the chief complaint could include the nature and the quality of the symptom, chronicity of the symptom, the location and the radiation, precipitating and relieving factors, associated symptoms, impact on function and activities, underlying chronic illness, and demographics. Now, among these components, we're going to focus today on contextualizing chronic illnesses and on demographics. So, talking about that and chronic illness and stigma, we can think about two main factors that affect the burden of stigma that are placed on particular disorders or conditions. One, perceived control that a person has over the condition. And secondly, perceived fault in acquiring the condition. The potential for stigma is even greater when the additional criminality or perception of criminality may be involved. Now, when stigma is great, there is a tendency for that to translate into patient communications and documentation where disease-first patient language is used. Now, I would ask folks, if you care to put in the chat some examples that you may think of when you're thinking about disease-first versus patient-first language. And in the meantime, I'll offer some examples myself. One, certainly with substance use disorder. Hello, my name is not my addiction. But how often do we hear 40-year-old addict or 40-year-old drug abuser who presents with, as an example? Hello, my name is not my body mass index. Why do we say 20-year-old obese female versus a 20-year-old female who is living with obesity? What about the 80-year-old demented individual who presented with? No, that is an 80-year-old individual who happens to have a condition referred to as dementia, and now actually has more modern designations as well. So when communicating the chief complaint, certain demographic details are often included. And hopefully they'll give context and orient the listener to the reader. And they may include age, sex, gender identity, race or ethnicity, socioeconomic status, occupation, and other contextualized features, including the chronic illness. Now, historically, demographic data were used as epidemiologic shortcuts to estimate disease probability. And certainly this was the way I was taught. But recent evidence continues to demonstrate that over-reliance perpetuates diagnostic inequities. And this we will focus on more throughout our session. So, speaking of language, I think that the words we choose really do matter, and we're also going to emphasize this point. George Orwell said in an essay in 1946, "Slovenliness or laziness in our language choices makes it easier for us to have foolish thoughts." Words are certainly informed by our values, but so too are our values reinforced by our words, and not only our own values, but the values of those around us, our patients, our learners, and as we'll point out later, even those out there in computer AI land. George Lakoff, a well-known cognitive linguist, said, "Language is not a neutral system of communication because it is always based in frames, conceptual metaphors, narratives, and emotions." As educators and healthcare workers and administrators who are forward-facing with our students, we really must be cognizant of the judgment inherent in our words. Figurative language is ingrained in our communication. In this sense, language is really an exercise in values decoding. So consider the topic of today's session, chief complaint. What might the word complaint conjure? Maybe it might evoke the idea of grievance or whining. Even the word whining is unpleasant. Dissatisfaction. It's really not a leap to wonder if this can implicitly frame the patient as a nuisance, as a burden, rather than as somebody who's come to us for help, somebody that we actually have the honor and privilege of helping. Educators have begun to advocate for terms like presenting concern, primary reason for the visit, or patient's concern simply. Language that enforces empathy, partnership, patient-centeredness. And henceforth, in our talk, we're going to refer to the chief complaint as the chief concern. So we're going to pivot. Health equity work in progress requires an acknowledgement and a reconsideration of previously taken for granted beliefs about health, about healthcare systems, and about society itself. And central to this is language. Our language become our messages, and they become our stories, and they become narratives which become deeply embedded in our culture, in our belief system, in our ethos. And those deeply seated narratives are also considered malignant narratives. Malignant narratives are those that serve the privileged group. Now, importantly, there's opportunity to dismantle if we really stop and reconsider and acknowledge. And that's part of our mission today. As healthcare educators, we have to be cognizant of the stage we have to role model communication that is free of unintended bias. And the impact we can everybody on this call can have on equity. Now, on the topic of education and health equity, a wonderful review came out just a few weeks ago. This was in the New England Journal, and it was titled Advancing Diagnostic Excellence Through Medical Education in Diagnostic Equity. And what it points out is that excellence in diagnosis cannot be separated from equity. And they described excellence in diagnosis as accurate, timely diagnosis for all patients, regardless of race, ethnicity, socioeconomic status, language, or other structural determinants. They define the term diagnostic inequities as disproportionate diagnostic errors linked to social identities such as race, ethnicity, and gender. They refer to this as a major barrier to diagnostic excellence. And this Venn diagram here shows diagnostic equity as an aspirational outcome resulting from the interconnection of clinical reasoning, communication, and anti-racist and anti-oppressive education. And so now let's pivot and focus on reimagining the chief concern for diagnostic excellency. Specifically, we'll focus on patient demographics, contextual labels and stigmatized chronic illness, and biased language used in the chief concern. So yes, let's react. Dr. Boutin-Foster.
Thank you, Dr. Jacobson-Dickman. And it is truly an honor to work with you. Dr. Jacobson-Dickman is the Associate Dean for Clinical Medicine. She's a professor of clinical pediatrics, and she's also one of our leaders in medical education and professionalism, as well in the learning environment. So thank you, Dr. Jacobson-Dickman. So let's react. So what I'm going to share with you is a paper that was written in 2022. And I have to tell you that this paper, and writing this paper, it was very emotional for me, because this was at the height of the COVID-19 pandemic, the murder of George Floyd and other events that contributed to a heightened awareness of racism, and really an urgency for us to respond. So this was written as a guide, an anti-racist based guide that would provide educators with intentional steps that can be taken to address anti-racism, discrimination, and bias in the clinical encounter. And while it is called REACT, it is not intended to be reactionary, but really it's intentional. And as I go through, next slide, please, the acronym, you'll see how it's really a lifelong practice. So reflect. So reflect calls us to really reflect and think about our underlying assumptions, our unconscious biases, as I believe both Doctors Reed and Rushdie alluded to, reflecting on who we are and why we think the way we think, what drive some of our assumptions. The next step is to educate ourselves. So we must educate ourselves on structural drivers, on policy, societal biases that contribute to poor health outcome, and ask ourselves what's driving patient health challenges. We also have to look at intersectional identities and see how intersectional identities cluster to create even greater oppression for some. So we must also educate ourselves and then assess our choice of words through word audits. You know, what did I write? How did I choose, and why did I choose these descriptors and identifiers, and cluster them in the way that they present in the chief concern or throughout the clinical narrative? And what are aspects of these descriptors and identifiers that contribute to stereotype? Are they necessary? Are they adding or detracting from the clinical diagnosis? And then there's an opportunity to call attention to potential harms that biased language and stigma can have on our patients, our learners, community as a whole. And you know, imagine when patients have the opportunity to read their notes, and the possibility of perpetuating bias and stigma. And then treat. So we want to treat individuals with dignity, respect, using inclusive language that signifies values and empowerment, not only during the personal interaction with our patients or with our learners or community members, but it's also in written form. It's also when we write things and when we talk about our patients. So react. Next slide, please. So in thinking of this framework, I really borrowed and learned from existing frameworks that are in the literature. So one is anti-racism or anti-bias, which many have discussed, which really talks about not only saying I am not racist, I am not biased, but really taking active steps to demonstrate through policy change, through approaches that you use. Dr. Kamar Jones and Ibrahim Kandi X described this in some of their work. Structural competency was developed as a framework to really guide learners to look upstream. In other words, not just to focus on the patient, their individual, but really some upstream factors. Metzel and Hansen were the colleagues who wrote this. And then trauma-informed care and trauma-informed language really calls us to recognize trauma, reflect on trauma, respond to trauma in a way that reflects value and validates the person as a human experiencing these traumatic events, and not re-traumatizing, you know, selecting words or not using words that can re-traumatize. And then intersectionality, developed by Dr. Crenshaw, really looks at the cumulative and overlapping identities that can create systems of oppression. Next slide. So we're gonna go to our first case. And I will borrow from Dr. Rushdi's talk and preemptively apologize. Dr. Jacobson-Dickman and I thought about these cases, we reflected on them, we modified them, and we thought that they were best suited to bring about discussion. So if there are cases that you think should be improved, respectfully, let us know this after the session, and we would be more than happy to build upon this. So the first case. And the context for this is medicine resident practice, late evening practice, and a resident comes and presents their patient. 26-year-old Black male in a wheelchair presents this evening late for his clinic appointment. As usual, demanding to have his M11Q filled out. He became agitated and aggressive when he was told that he missed his appointment but refused to reschedule. So let's react and reflect on this. What are words and terms that could be stigmatizing and are stigmatizing and can perpetuate bias? You can just put them in the chat. Okay. Yes. So there are many words that that create opportunities for bias. And while that may not be one's intention, but in writing, it's really important to be intentional and reflective on what we write, because it is so important. Because what you write, someone else will read. And what you write today becomes the patient's history. So let's educate ourselves. What does the literature say? So there's data there that there's literature that describes differences and really just biased language, especially when it comes to talking about Black patients and women. So this article, there's several articles, but these two articles, the first one is actually by Sun, who describes who in this study identified that Black patients were almost 3 times as likely to have one or more negative descriptors in their chart. And this was patient refused, patient was non-compliant, patient was agitated. And sometimes we write these things, it becomes practice, it becomes part of our common language. And we don't take the time to appreciate what impact this will have. And another article looked at 30,000 notes. And both of these studies use natural language processing to summarize the key findings of multiple notes. And you see words such as angry, aggressive, challenging, combative, uncooperative, defensive, hysterical, resist. These words are weighty. They have meaning. Next slide, please. Another study by Beach and colleagues looked at over 9,000 notes that were written by over 165 physicians on 3,000 unique patients. So it's a lot of notes to comb through. And what they found in this study was that Black patients had higher odds of containing containing words that were stigmatizing. And they categorized these as evidential statements, casting doubt on the source of one's knowledge. Judgmental words that question credibility, the patient claims, or the patient states. And while there wasn't, when comparing male and female patients, there weren't differences in the proportion, significant differences rather, in the proportion, but of negative words used, but the use of quotes, patient says that she has a rash. Patient says that she has pain. So putting things in quotes, what does it mean when we do that? Is it really to highlight and to call attention or to cast doubt? So there are differences in how notes are written. So next slide, please. So so we see that what is written there's this difference. It's been documented that there are differences, disparities in how notes are written based on one's demographic. Now, what impact does it have? Like, what does it mean? What impacts? They're notes. They're just notes. I'm just writing down notes. What do they mean? Well, they do have an impact on our learners. So studies have shown that what we write becomes part of the resident's training. It becomes part of their socialization or the hidden curriculum. So the first study by Godot and colleagues, this was a simulated, a hypothetical case of I believe, 28-year-old male with sickle cell disease. And trainees were presented with notes that were deliberately stigmatized and those that were neutral. And they found that among those who were exposed to the stigmatized notes about this patient, that there were, when they went and then did an outcome assessment to look at the impact that this had on positive attitudes, they found that trainees who were exposed to a negative note about a patient, a hypothetical patient, or it was a note that had stigmatizing language rather than a negative note, that these trainees had less positive ratings of their patients, and also it impacted their prescribing methods and the extent and degree to which they would prescribe pain medications. Another study looked at using a similar approach of randomizing residents to receiving stigmatizing notes versus non-stigmatizing notes, found that among those who received the stigmatizing notes, there was a greater chance of having poor recall. So they were less likely to recall what was written. So this was done as handoff. So as residents, you always have the handoff. When I was a resident, we had this little piece of paper that you would fold up and put in your pocket, and you would describe, check labs, check CBC. And when this was embedded within negative notes, that recall and clinical accuracy was less. And then this study also looked at their attitudes towards their patient, and that was also diminished. So what we write matters. It impacts it impacts our learners and ultimately patients. Next slide, please. So, okay, so what about our patients? How do our patients feel? So this study was done among 22,000 patients recruited from multiple health systems, and I believe it was in Boston and in Seattle as well. And this study asked patients who read their notes, did they feel judged or offended by what they read? 10% of patients responded yes, endorsed that they were either judged or felt offended. They felt judged or offended. And their responses were then qualitatively categorized into three themes. One theme is errors and surprises, that what was written was wrong, and I'm surprised that, the doctor even said that. I never said that. The next theme was labeling patients. I felt judged. Yeah, I was offended by what was written. And then the third theme was disrespectful, and I feel misunderstood, such as the patient denies. What does it mean, like denied? Again, casting blame and doubt. So in essence, what we write impacts our learners and patients as well. So if we go back to our case, so we've reflected, we've educated ourselves, let's assess. We talked about the words here, and what do they mean? Why would putting race in the chief concern contribute to perpetuating stigma or stereotypes? And what does it add? What does it add to this, really? And what is the potential for this term, for Black, to be misused unintentionally, unconsciously, or even intentionally to make decisions? So we reflected, educated, assessed, call-in. So again, this was a case that was presented late evening practice. And this is really an opportunity to call in our learners and say, what I see what you wrote. Can you tell me what were you thinking? What would you like to do? Let's talk about this case. And it turns out that the resident made assumptions about who this person was. There may have been multiple things that led to this assumption, but assumptions were made, and there were not positive assumptions. Next slide, please. I think so treat. So let's go to how we would rethink and reimagine this. So 26-year-old male presented to clinic requesting to have his M11Q filled out, period. There's nothing wrong with that. Patient has the right to do this. And it turns out that this patient was a graduate student who had a motor vehicle accident at a very young age, and since then required the assistance of a wheelchair to get around. So our practice was downtown, and his graduate school was not downtown. It was uptown. And he was, I think it was before the dissertation, it's the exams that you take before the dissertation. It wasn't quite the dissertation. And this person was also a TA and would schedule appointments after his last class. And would say that M11Qs were mailed in the past, but I didn't get them, and it's easier for me just to come. Let me help you out so you don't have to mail it. And this is how, and this was a presentation, but unless you take the time to find out about the person who comes in as a patient, one may make assumptions. So this is an opportunity to reflect, educate, assess, call in, and treat. Okay, next slide, please.
Okay, thanks.
It's on you.
Thank you. So this is the second case that we have, and the context is an emergency department day attending, signing out to the evening shift team. So this is the chief concern. 40-year-old transgender man presented with severe arm pain after falling off a tall ladder. So let's think about how to react, beginning with reflection. And reflection is really a way to self-audit. Ask yourself, am I happy or am I not happy with what I have done? And in this case, what I have written or how I've presented. And to think, is there anything here that is unhelpful? Anything that could be potentially hurtful, or is it perfectly respectful? So the consideration in my mind would be transgender. Is it necessary to include here? Is it helpful in thinking about the goals of our medical interview and particularly of the chief concern? So with that in mind, a little bit of education. So there's actually a term called trans broken arm syndrome, which is also known as gender-related medical misattribution and invasive questioning syndrome. And this is a form of medical discrimination and bias where providers either explicitly or implicitly link unrelated health issues to a patient's transgender status, or focus excessively on aspects of the transitioning process rather than the acute medical issue at hand. This can lead to delays in care, distress, breakdown in trust between a patient and a provider, and nearly 1/3 of transgender and gender diverse individuals report experiencing such misattribution or invasive questioning, which is associated with a broader experience of discrimination in the healthcare setting. So it brings us to asking ourselves, what are the potential benefits of the inclusion of the status, particularly in this situation, and what are the harms, right? Dr. Rushdie talked about do no harm. So what are the benefits? Well, perhaps we may be alerting providers to unique health risks. In this situation, I would assess that wouldn't be the case. Maybe it can result in supporting respectful, affirming communication, enhancing trust and satisfaction. It may enable individualized preventative care and screening in certain circumstances, not necessarily in an acute setting of a injury. And the potential harms already referred, risk of medical misattribution, invasive questioning, breach of confidentiality and social harm if the transgender status is disclosed without medical relevance and certainly without explicit consent. And increased risk of microaggression in many places in this country, care refusal even, and great psychological harm. And so a guiding principle, if one is thinking about whether it is appropriate to include, is to ask yourself, is it clinically relevant? And am I including it from a place of respect for our patient and for enhancing respect of their care. And so in this case, I would come back and assess that it would not be relevant to their care and can result in the syndrome of misattribution and evasive questioning, and erode trust of our patient in our care, and perhaps delays, et cetera, et cetera. And so then we get to the C, the calling in of the attending. How would we do that? We mentioned that the context was in front of a shift team. Perhaps a conversation with hopefully a very well-intended attending, a colleague. Oh, I noticed you mentioned the patient has transgender status. Why would you mention that here? Let's talk about it. Perhaps there is a reason. Perhaps the patient asked the attending to make sure folks were aware and wanted to be affirmed. That's a conversation that would be important to know. Perhaps the attending thought this could be helpful and is really open to being educated, as is the team. But certainly a conversation that addresses it and perhaps will result in behavior change in the future could be very appropriate. And so let's treat this person with the respect and with the timeliness that they deserve, being in pain after falling off a tall ladder, and simply say this is a 40-year-old man presenting with severe arm pain after falling off a tall ladder. Dr. Boutin-Foster.
Thank you. Thank you. So our final case, this is a faculty who's writing a case for a team-based learning session and asks a colleague, you, to review a vignette that they plan to use in class. So they wish to use this. Terry, a 56-year-old obese, diabetic, homeless white woman complains of worsening left-sided throbbing pain. So let's reflect. And what are some of the words and choices of words in this clinical vignette that is planned to, the plan is to use it to teach students. So you can put it in the chat. What are some words that may perpetuate stigma or can be said differently? Thank you. So now let's see why are we talking about this in terms of equity and the environment and the learning environment. So you pointed out obese, diabetic, homeless, white, complains. So next slide, please. Thanks, Dr. Dickman. So in the context of equity, equity requires that we value individuals, not only in the way we speak, but also in written language. And that impacts how we treat our patients. It requires us to value individuals and populations equally, recognizing historical injustices and providing resources according to need. And inclusive language is a way that is a way of referring to people and their identities and their bodies with care and dignity and respect. And at its core, it's patient-centered. It engages patients. Again, it demonstrates respect and an understanding of values. And it recognizes systems of oppression and bias. So recognizes the words that we use are weighty. The words that we use can impact. It seeks to minimize re-traumatizing, and it avoids perpetuation of stigma and stereotypes. Next slide, please. So as this slide says, hello, my name is not my disease. Now, we talked about the impact of language in the clinical chart, the chief concern, the patient narratives, the impact that it is pervasive, that there are biases with Black patients and female patients having greater negative language or stigmatizing language in their charts, as well as the impact that it has on our learners and patients. But there's also this lasting longevity that AI introduces. Now, EHR serves as a major source of data for many prediction models and tools and large language models. So this study looked at well, what is the impact of having these stigmatizing language on the performance of AI? So one study looked at over 500,000 patient notes. Patients were admitted to the hospital, and the ICU was one of the settings that they looked at, not the only setting, but one setting. And they found that on average, 21%, almost over 20% of notes contain stigmatizing language. And it's the language that we talked about before, whether it was aggressive, demanding, denies, all of these terms. And they also found that Black patients had almost twice the higher likelihood of having stigmatized language in their notes. And what does this mean? That these models are making predictions on words, right? The models are computers. They're not having this discussion to think about, well, what do words mean? They see words and they make assumptions based on the cluster of words. So greater number of stigmatized language was associated with low predictability of mortality prediction. So these algorithms were less likely to accurately predict mortality, which impacts patient care. So next slide, please. So words are impactful. So if we go back to this patient and we pointed out the words that are problematic, this is so we've assessed. It's an opportunity to call in our colleague and say, what was the intention? What did you want to do? What was the goal? What were the learning objectives with this case? And rephrase it. So it gives us an opportunity collaboratively together to treat our patients, our hypothetical patients with respect. So to say, rather than obese, diabetic, homeless, white woman, to say this is a person living with obesity, diabetes, and currently experiencing homelessness and presenting with worsening left-sided thrombin pain. And one may say, well, why do you need any of this? Again, it depends on the intention. If the goal was to have your students to pick up on this and to think about chronic comorbid conditions, to think of chronic occurring clustered conditions, to think about structural drivers of health and to pay attention to this history, then perhaps mentioning these terms up front. But it's the way in which you do it, because otherwise it's a distraction and it pulls you away from learning. So next slide, please. So we're going to throw a wrench into this. So this case was one of our cases. And Dr. Jacobson-Dickman and I really modified it. We modified it so it could be a little bit more palatable. And this was presented to us by one of our graduates. Our students were great. One of our graduates who came to us and said, hey, look at this. We saw this. And I actually thought it was that someone deliberately created this to highlight this point, but unfortunately it was not. But we had an opportunity to work with the faculty members and really look at this and say, how can we say this differently? So it was an opportunity to learn, to call in. This demonstrates what Dr. Jacobson-Dickman alluded to before, the co-learning, the co-mentorship, collaboratively working to address inequities in written form, collaboratively working to promote excellence, diagnostic excellence, educational excellence, working collaboratively to really support a positive learning environment. So kudos to our students. So Dr. Jacobson-Dickman, please take it home.
So what are our take-home messages? Firstly, the chief concern anchors the medical interview, balancing the humanistic and scientific aspects of care while identifying the primary reason for a visit. It guides the evaluation, diagnosis, and treatment process, so extremely pivotal. Stigmatizing language and demographic labels presented without context perpetuate harmful narratives, reinforce discrimination, health inequities, and non-inclusive learning environments. The words we choose in clinical documentation and interpersonal communication not only shape learners' perceptions and practices, but also influence the EMR AI system, embedding bias into future algorithms with very amplified impact. The brilliant REACT framework provides a structured method to reflect and revise clinical documentation, interpersonal communication, and teaching materials, fostering empathy and diagnostic equity in both practice and pedagogy. Thank you so much for your attention. And Dr. Carla Boutin-Foster and I would be very pleased to hear your comments and address any questions that we might be able to. Oh, yes, Dr. Bianchi.
Yeah, I'll come out of my shyness. And I really appreciated this presentation. It was really great, both in terms of providing a broad and foundational research-based also a set of data on where the latest research is on these important issues, but also the idea of presenting concrete cases and discuss them. My question is, we all know how often questions in national standardized board exams are written. Where are we with changes perhaps in adopting this framework and these changes into those questions? Is there any discussion at the national level, for example, that indicates that there will be changes, basically? Because obviously they set an example for many,
I can give a start, and Carla, please feel free to jump in or to correct me. So I think that there's a lot of discussion from educators. One, personally, and I think others would remark on this, one of the limitations is that we are not always on the same page as the billers. And ultimately, we live in a society where we need to turn on our lights in hospitals, and healthcare systems are not thriving. And so there's so much emphasis on survival, and financial survival is survival. So if we don't sort of allude to the recognized vernaculars, like chief complaint, for example, which many of us would have thrown out a long time ago, we have to have more alliance, if you will, which is a pervasive argument for many more aspects of our care. But that is a limitation. But yes, there are conversations at levels of like AAMC about language, certainly gold humanism and such. Dr. Boutin-Foster.
No, I agree. There's definitely conversation at the undergraduate undergraduate medical education level. What I've observed and what I've seen in just my own licensing exams, that they acknowledge that race is not a biological construct. So for instance, they in the section on renal, for instance, it will acknowledge that race has been removed from the EGFR, and now there's the new FECKD formula that's used that does not have race. Other formulas, such as the atherosclerotic cardiovascular disease, ASCVD, Dr. Lazar's on. I want to make sure I get my cardiology acronyms correct, but they actually will have a case with saying this is a Black patient. And then they'll have like a caveat, by the way, we know that race is not a biological construct, but why include it anyway? It's already in the question. I'm like, all right, I already took the question, I already answered the question. Now I have to go, so they're moving, but there's this explaining, why are we doing this? So they're making slow steps to acknowledging, and in some places take corrective steps.
Thank you.
I just wanted to chime in on that as well as from a medical student perspective. When I was taking step one and step two, I'm not sure if it's because every time they ask me a survey about, do you think this is representative of your patient population? I'm like, no. So I don't know, maybe there were more experimental questions on some of that I remembered that they are starting to incorporate more gender diversity and more language that are less biased. So I have noticed some of that change on the national board exam level. So I think they are making rudimentary effort into moving away from buzzwords, and buzzwords these days includes race and ethnicity as well, and gender diversity. So I think they are starting to move a little bit more away from those type of buzzwords into more disease-focused prompts and vignettes. So I have seen some of that effort on the national level. So I just want to chime in on that. And I will say that I also have, because I think I've noticed some of these language more because I've been primed at Downstate when we learn about these type of language. So I feel very prepared whenever we read those questions. And I was like, oh yeah, like we have been trying to do something like this at our institution too. So this makes sense.
Thank you so much for that comment. And that's really a perspective that only you could offer as a student. Dean Lazar.
Thank you, Dr. Jacobson-Dickman. I had a question. You painted a very compelling picture that the chief complaint really impacts a variety of student perspectives, patient perspectives, and electronic medical records / AI modeling equations, algorithms, I should say. Is there any data to suggest that the stigmatizing language in the chief complaint self-perpetuates itself throughout the remainder of the medical note?
I'm not quite sure if there's studies that have looked at that, but when you look at the chief complaint, some of the even in chart reviews, you'll see that the words are sort of propagated from the chief complaint, the chief concern to the rest of the notes. So there are studies that show where are these words, and you see it. You know, as Dr. Jacobson-Dickman says, it sets the stage. If you start out saying that this is a Black male patient who's agitated, the rest of it continues. So it does continue throughout the rest of the narrative. So it's the opening statement. It really is.
And I would add, and this isn't exactly answering the question, since I don't actually know studies that looked at that, the data, but I would say that, you know, we know that whether it's right or wrong, there is a lot of this pace forward culture. So, you know, if we talk about amplification, I mean, obviously AI is its own level. But just the idea that, you know, somebody else is going to start like literally, not just influence, like literally using your language or one's language, that has potential to not, you know, to really change the outcome for that patient based on implicit biases. It's a tremendous responsibility. And it's the first thing you see. It's so pivotal. So thank you for your question, Dr. Lazar. I'm sorry if we didn't know the exact answer, but I'm going to look into it and see. But I didn't come across any data that responded to that specific question. So perhaps it's a study to be done.
Yeah, that was my thinking exactly. You know, in many assessment and plans that I see, they start out with the chief complaint. So literally verbatim. And I'm just wondering if that chief complaint, which impacts all of the issues that you poignantly illustrated, also is one of self-perpetuation throughout the rest of the documented medical note about a patient. And I actually think that would be a very interesting question to ask in terms of medical education. Just food for thought.
I agree. I think it's fascinating. I wish I knew the answer, but that's the call.
But I'm sorry,
please.
if I may, we do know that just changing the race in the chief complaint impacts the differential that follows. So there are studies that show that, and that has been the rationale for not including race in the chief concern, because not that it's bad, but unconscious biases may flourish just based on the patient's race and nothing else, and start making diagnoses that are really based on stereotypes. So we do have data to support not including, and I think at Downstate, we don't do that for the most part, but there is data that demonstrates that.
Thank you.
And so we have one more question, and then I think we'll move on for the sake of sticking to our schedule. Dr. Berkowitz, please.
Thank you. I'll try to be quick. I just wanted to make a bit of a comment. I think this was such an important talk. Thank you so much, Dr. Jacobson-Dickman and Dr. Boutin-Foster, for presenting it as such, because I really think this is so complicated. It really has to do with a whole formal way of re-educating practitioners on what this means and perpetuating stigma through language. And the reason is that we're taught, at least some of us older folks are taught, that a very important aspect of presenting data has to do with identification. And, there are certain aspects, and this is really contextual, because there are certain aspects which I think that both of you brought out in your examples, where perhaps it shouldn't be in chief complaint, but perhaps things like Black or wheelchair or things could be predisposing factors in a differential diagnosis, or something that we see more prevalent in a certain race or a certain disease entity condition. So it really is a sort of reframing of the entire educational process in identifying language. For me. So to me, it has to do with contextual. It has to do with whether you're looking for a disorder, whether it contributes to making a differential, pertinent positives, pertinent negatives, things like that.
Yeah. So thank you so much for those comments, Dr. Berkowitz. I think part of the discussion, is really related to markers of risk versus the new recognition, or, at least new compared to when we were taught in the day, of risk factors versus markers of risk factors, which can be conflated and be dangerous. So I think that's why, the prominence of the chief concern can mislead people, and certainly, related to the conflation of biology with social constructs. And so I think that's part of the danger. And that's, I think, what you're getting at as well, that there is context where someone might, later on mention the wheelchair, as you say, because there are needs the patient would have that we can help them with if we understand that, versus painting that person in a way that might bias yourself, even unconsciously, or your team, or those that later come to the table. So thank you so much for that comment. This conversation is a really important one. So for the sake of time, I think, even though we can probably talk about this for hours and hours, and I hope we will, I think we will move on